The topic that we are going to see now is articulators. Introducing articulator. What is an articulator? A prosthodontist or a dentist's most important instrument, armamentarium, is articulator. What is that? And why is that important to us? What is there in our mouth, in a patient's mouth? We have a temporomandibular joint, we have a mandible, we have a maxilla, we have a base of the skull. How will we reproduce these particular arrangement in a lab when the patient is not there, or to do other works? So then came up is something which is known as the articulator. So definition according to glossary of prosthodontics terminologies 8 goes as, it's a mechanical device that represent the temporomandibular joint and the jaw members, that is maxillary and the mandibular arch, to which maxillary and mandibular cast will be maintained or attached to simulate the jaw movements. So how we move our jaw, the same movement should be happening in an articulator after the maxillary and mandibular casts are attached to that particular instrument. So that kind of mechanical device is known as an articulator. There were n number of development from years together where different kinds of articulators came up, where the starting articulators were, then there was advancements, then further advancement. We will see how the classifications of the articulator came over years together, and now we at least have an articulator which somehow to the nearest reproduces our temporomandibular joints and simulates the jaw movements. What are the requirements of an articulator? We need to have some requirements for the articulator. It is classified according to Winkler into two groups, the minimal requirements and the additional requirements. Minimal requirements are those requirements which are ought to be there in any kind of articulator. Those are, the first one should be that articulator should simulate the jaw movement. That is a basic requirement. Second is that it should have two members where maxillary and mandibular cast can be attached. The third important thing is there has to be certain parts of an articulator which are movable. There has to be certain parts of articulator which are to be rigid. The parts which are supposed to be movable should be freely movable, like a condylar guidance. The parts that is supposed to be rigid should be rigid in its place and it should not be moving, like the incisal table. Incisal guide pin, it should be again moving. So we will come up to the different parts of articulator. What are the other minimal requirements? It should be able to accept the phase bow transfer. Phase bow is what? Phase bow is a device which reproduces our static relation of the base of the skull to the maxilla. So it actually makes us understand that how is the maxillary arch related to the base of the skull. Will come in the near future classes. Next requirements are the additional requirements. What are the additional requirements required in an articulator? That is, it should have a lateral guidance, it should have a protrusive, it should have a lateral guidance. What does that mean? That means that it should be able to go to right and the left lateral movements that a patient can do. An articulator can simulate that kind of movements. So those are the additional requirements. What are the advantages of an articulator? Talking to the patient's point of view, less chair time appointment for the patient. You have to just make two models, make an impression, pour the cast. Your two models are ready of maxillary and mandibular arch. What else for the patient? The patients, we cannot view the lingual side of the patient as a dentist. So if we have an articulator, we can move the articulator in the lab on any side and we can view from the lingual aspects as well. Coming to the dentist point of view, how have we benefited with the articulator? First and foremost, I told you, the lingual view. Second is occlusal adjustments not on the patient. It takes a lot of time to adjust any occlusal discrepancies which are present in the patient's mouth. So rather, why not we do it in an articulator in the lab and then simulate the same thing in the patient's mouth. That saves our patient's timing in the particular clinic as well. Another important for dentist is we can give it to our lab personals who are there, so they can help us out with that. So our time is also saved, chair side time is saved, lab time is saved. So this is what are the benefits of an articulator. The purpose of articulator is when the patient is not with us, The patient is simulated with an articulator. So we cannot have the patient in every time while preparing for crowns, preparing complete dentures. The only thing that we need to take in mind is the purpose of articulator will be only solved if we have taken a centric record of the patient. That there should be a static record, and which static record will we follow? We will follow the centric record. So that centric record should be there in the articulator. Also, the articulator should be able to take a right lateral, left lateral, or a protrusive record for further benefits of as a dentist to plan the treatment. Important in aspect of complete denture, it helps in balanced dentures. Important in aspect of fixed partial dentures, it helps to remove the high points in a particular crown or any bridges. So these are the purposes of articulator which is solved, and only if it solves the minimal and the additional requirements, the purposes of the articulator will also be solved. Coming to limitations of the articulator, it is very important to know that an articulator is a mechanical device. Any instrument needs calibration after a certain period of time. Similarly does our articulator. So an articulator is either made up of metal or a plastic. So accurate calibration of these materials and instruments are not possible. So that is one important limitation. Second important limitation is you cannot 100% simulate what is there in oral cavity in an articulator. It is a nearby thing that we do with the help of an articulator, because not all the articulators can take up lateral and left lateral, right lateral movements. Not all the articulators can take up protrusive movements. More than that, not all the articulators can record, any articulator cannot record the functional jaw movements, the border movements of our mandible. It can only be in one unidirectional movements that can be recorded. The multidirectional movement that our jaw is supposed to do cannot be recorded in a particular articulator. So these are further limitations of an articulator, but what we need to choose is what is the best amount for all of us. Coming to the classification of articulators. As I told you earlier, there was n number of years where n number of different models of articulators came up. So University of Michigan finally decided in 1990 to give up a classification which will be recommended to all those articulators which was discovered, coming to the latest articulators that we use today. So the classification of articulators by University of Michigan, which was proposed in the year of 1972, Class 1 subdivision A, subdivision B. Class 2 subdivision A, B and C. Class 3 has A and B. 4 again with A and B. We'll see one by one. Coming to the first classification of articulators, which was the earliest of history times when articulator was discovered. That time the only thing in everybody's mind was the vertical movement possible. No horizontal, nothing. A vertical movement is possible. So those kind of articulators which is acceptable for a static registration is class 1 kind of articulator, where only vertical movement was possible. For example, verticulator. We still use verticulator for our full mouth cases, but yes, those are not for the regular patients to simulate an articulator. Why? Because it cannot take the lateral records, it cannot take any records, it cannot accept face bow, so we are helpless to eliminate it. Coming up to subdivision B, that is also it takes vertical movement, but it had a hinge joint. There was this little change which came up in history of articulators. For example, a dinar corp articulator which had been developed, the centric relator articulator is also known as. So those kind of articulator had a hinge, but again the same thing, it could not go beyond a class 1, that is it cannot go beyond the vertical recording of the articulator. Coming to class 2 kind of articulator, little more development happened when people came to know that no, not only vertical, we need to also do some horizontal recording, because there is right lateral, there is left lateral. So where these kind of articulators came into picture, Dr. Geisy, who was a mechanical engineer for that matter, Geisy's simplex articulator which was developed, it is the simplest articulator which was given by Geisy in the first time, where eccentric motion was permitted, but it was based on arbitrary values. How does that arbitrary value come from? The condylar guidance that we are supposed to take is 30 degree. The incisal guidance that we are supposed to take was 0 degree. So this was the arbitrary values which was taken, and based on that the articulator was developed. So Gritman articulator is a kind of example in those kind of articulators. Subdivision B was what? It had also taken the values, but now there was Monsoon sir who came into picture. Monsoon sir gave a beautiful theory of occlusion, which is said the theory of Monsoon's occlusion. There we have spherical theory of occlusion, we have conical theories of occlusion. So all these theories of occlusion were converted further into some one articulator. So we have Monsoon articulator, we have a spherical articulator, we have a conical articulator based on the theories of articulator occlusion. Subdivision C is eccentric motion permitted is determined by using records from the patient. Now what new technology came up? They started taking an AluVax record of the particular patient, and that was simulated and mounted on the articulator. Like the gnathic articulators, these were used. Coming to the class 3 articulator, almost the articulators that we used in day-to-day life of today is the class 3 articulators. Like Hanau non-Archon H2 articulators. We have even Hanau Archon articulators, which is most widely used today, taken by Wideview company. Subdivision A, what are those? Those are those instruments that accept static protrusive records, and they have the rest of the motion which is possible in that. Okay. Whereas subdivision B will come up to those which will take the static lateral registrations also. So the left lateral, right lateral and the protrusive records can be taken in subdivision B kind of articulator, like the Whitmix articulators, or we have Hanau Archon H2 Wideview 2 articulators. Coming to class 4 type of articulators. What are the class 4 type of articulators? Those are the newly advanced articulators. Those represent and simulate exactly the temporomandibular joints. That is, it is based on the pantographic records, stereographic records. So the class subdivision A is stereographic articulator, subdivision B is pantographic. How does that differ? Is these articulator take the directly from the patient. Like subdivision B, you can see those are those instruments which have the condylar path that can be angled and customized either by selecting from a variety of curvature or modification or both. That is, those articulators which could have simulated the exact condylar pathway, the exact Bennett movement, the functional border movements. So those kind of articulators were subdivision B kind of articulator. We have Dinar D5A articulator, which is this example of this kind of fully adjustable articulator. Rihani in year of 1980 came up with a very simpler classification of articulator, that is non-adjustable, adjustable and semi-adjustable. Non-adjustable articulators are those articulators which cannot be adjusted. Semi-adjustable articulator like Hanau H2 Wideview articulators, those can be little adjusted. It can take over the lateral records, it can take the protrusive records. Then fully adjustable articulators, like we have the stereographic, Dinar D5A articulators. They can take up all the records, all the border movements. So those came up with the fully adjustable articulators. Coming up to Archon and non-Archon kind of articulator. Very difficult concept to understand. To simplify it, we can know it like this. Archon, the word itself has two words, that is articulator and condyle. Ar for articulator, con from the condyle. So those articulators which simulate the condyle of the human, like how we have the condyle is with the mandible, we have a glenoid fossa where it is going and attaching and then it slides down. So this kind of arrangement in any articulator will be known as Archon articulator, like the Hanau H2 Wideview. Those articulators which have the condylar element in the upper membrane and the condylar path in the lower membrane. That is, the condyle in the upper side and the glenoid fossa in lower side. These kind of articulators, those will be known as the non-Archon kind of articulator. The term was administered by Brexter. Coming to the parts of an articulator. What are the different parts of articulator? We have condylar guidance, we have Bennett angle adjustment, we have a centric lock, we have an incisal guide table, we have an incisal guide pin, we have a condylar relator, a counterpart of a earpiece, we have accessory attachments in a particular articulator. These all parts of articulator are specially for Hanau articulators, which are widely used by prosthodontists. Let's see one by one. What is condylar guidance and condylar element? Condyle, how it travels in the glenoid fossa to simulate the same thing in an articulator will be known as the condylar guidance. Now that condyle is termed as condylar element in articulator. The glenoid fossa path that it is following, that path will be called as the condylar pathway. So we can see that arrow with a yellow. So that path which it is following is the condylar path. The yellow round structure will be the condylar element. So if this condylar element is in the lower membrane, so that is again a Archon kind of articulator. If that condylar element is in the upper membrane, then that will be called as a non-Archon kind of articulator. Now, how does that differ and matter to us from patient to patient? It differs from every patient because every patient has a different kind of condyle, a different pathway that it follows. So every patient will give you different angulation of condyle. So we are supposed to record that condylar guidance with the help of our protrusive records. Protrusive records will give us condylar guidance. What is the average value? Is around 30 degrees. So this is our condylar guidance. This is a picture of Hanau H2 wide view. So where we are supposed to keep the Bennett calibration, which is on the top, to 30 as zeroing of articulators suggests of Hanau. We are supposed to keep the protrusive calibration to again 30 and the incisal table that will show to 0. So we can see a condylar track where the condylar element follows. So this is how a condylar guidance is supposed to be in an Archon kind of articulator. Just imagine this to be the other way around, that if the condylar element was on the upper membrane and the condylar pathway with the attached to the lower membrane, like in Hanau H2. So in those kind of articulators, those will be called as non-Archon kind of articulator. Even our mean value articulator is a kind of non-Archon articulators. Coming to incisal guidance. What is incisal guidance? It is a guidance which is given by the incisors of our own patient. That is, what is the overjet and overbite? What is an overjet? Overjet is the horizontal overlap. Overbite is the vertical overlap which is present. So now, if it depends, if the horizontal, the overjet is more and overbite is less, so we will have a different incisal guidance. If our overjet is more and overbite is less, we will have a lower incisal guidance. What is more favorable to us? We should have less of overbite and less of overjet to be restricted to 1 and 0.5 mm respectively according to the new edition of Boucher. Coming to incisal pin. Now different kinds of incisal pins are available in different articulators. Can be dual incisal pin, dual end that will have a chisel end and arrow end. It can have a micro pin, it can have a curved incisal pin, we can have an adjustable foot. Now the incisal table that we have, it can be either customized, like in case of whip mix, we need to customize for a full mouth case, full mouth rehabilitation cases. For how will we customize an incisal table? That can be either done with a composite, that can be done with acrylic, something by which you will move the incisal pin along the incisal table and record. But our Hanau H2 wide view Archon kind of semi-adjustable articulator already has a wings on the incisal table. So you can adjust your incisal guidance according to the patient without customizing the incisal table. So we have adjustable incisal guide table like in the case of Hanau H2, that what I spoke about. We have flat plastic incisal table like I said in Whipmix we have. We have custom incisal guide table that you need to do as I described earlier. Coming to basic components of an articulator. What are the basic components of an articulator? Which articulator am I talking about? I am talking about mean value articulator. So the different components and the basic components of the articulator is an upper membrane. What will it represent? A maxilla. A lower membrane, that will represent a mandible. A condylar tract, that is the condyle where it is supposed to move the glenoid fossa. It will simulate condylar element that will simulate the condyle itself. The vertical rod, that is the incisal pin. The requirement should be that incisal pin should have a stability when it is locked. Why is that so? So that acts as an anterior reference point for us. Then we have an incisal guide table. So you see a condylar element present, a condylar guidance. The condylar tract we can see from where the condylar element is going to move. We can also see the lower membrane and the upper membrane. We have the mounting plates where the cast can be mounted out and it can be removed in the particular relation. Incisal pin, we have a guide table, the incisal guide table. These are the different parts of articulator. What are some commonly used articulators? Are mean value articulator. Why is it called mean value articulator? It is called mean value articulator because it is based on the arbitrary mean values of condylar guidance, incisal guidance and the Bennett angles. 30, 30 and 0. So based on that the articulator is made. So it is also called as a 3-point articulator or a mean value articulator. Hanau articulator, different Hanau articulators are there. Hanau H2 wide view. We have Whipmix, Dinard, TMJ articulator. We have dentatus articulators as well. So this is a mean value articulator, different parts of mean value articulator. Mean value articulator is a type of a non-Archon kind of articulator. As we can see, the condylar element is in the upper membrane. We have a lower membrane with the condylar path engraved in that where the condylar element is going to travel. So this is another kind of non-Archon articulator. The incisal guide table, it is almost flat with some average degree, the mean degree that I said. How much is the mean degree? That is 0 to 5 degrees. So within that it is fabricated, it is made. So there is a reason that is called a mean value articulator. We have condylar guidance which will follow the condylar path. We have a vertical rod or incisal pin which is directly forming and stamping on the incisal guide table. It should be stable enough. So many articulators all in the market. So which is the articulator that you need to select? Selection of an articulator is very important. So coming to selection of the articulator for fabrication of complete dentures. What are the criteria that you need to keep in our mind for fabrication of a complete denture and selection of an articulator? The first is what kind of occlusion that we are planning to give. Are we planning to give a balanced occlusion? Are we planning to give the occlusion that is already present in the patient's mouth? Or are we planning to change the occlusion that the patient is already habituated to? So that will decide. If we are planning for a balanced occlusion, we need to have a semi-adjustable articulator. If we are planning for the occlusion which is already present in the patient's mouth, then a normal mean value articulator will also do. Secondly, what kind of tooth movement is assessed by us? That is the guidance canine guided or is it group function? Big terminology. Canine guidance. Canine guidance is when the patient moves lateral excursion movements. If the canine and canine comes in contact and all teeth are out of contact, those kind of occlusions are called canine occluded guidance. Canine guided occlusion. Those if all the posterior teeth come in contact when you have a lateral occlusion, lateral excursion movements, like in cases of adhesion cases, so those will be called as group function. And the canine guided is another example of a mutually protected function. What is that? So the anteriors are protecting the posterior when the anterior are in contact. That means when you do a protrusive movement in our mouth, when you keep the incisors to incisor contact, the posteriors are disoccluded. When you are doing a lateral movement, the canine and canine is into contact, rest everything is disoccluded. So mutually they are protecting each other in different kind of excursion movements or protrusive movements. So that you need to decide if this kind of completely you have a canine guided occlusion or you have a group function occlusion, then you need to go ahead with the semi-adjustable articulators. Then the criteria that will decide that is which is an easier form of your technique. That is, if you are planning to give a complete denture, but yes, the patient requires it in a few minutes time. You cannot afford to take a protrusive record. You cannot afford to take a lateral excursion records. So then you have to adjust with the mean value articulators. Selecting the articulator for fixed prosthodontics is another beautiful challenge for a prosthodontist. What are the different techniques that you need to undergo in mind, that you need to decide before selecting an articulator? Same and foremost important is the patient having canine guided? Is the patient having group function? If it has, then we have to go for a semi-adjustable articulator. What are the occlusal adjustments that we are supposed to do in the patient's mouth? That has to be done in articulator before. If the adjustment is of longer period of edentulous, like we have a 7-unit bridge or 6-unit bridges, so that time you require a semi-adjustable articulators, because you have to do excursion movements, right lateral, left lateral movements to find out which is the high points. So to eliminate that, so to eliminate all those things, you need an articulator which can simulate all this. So again we need a semi-adjustable articulators. For a full mouth case, full mouth rehabilitation, when you want to change the entire, rehabilitate the occlusion, rehabilitate the outcome of the aesthetic outcome of the patient, that time again you will require a semi-adjustable articulator. Whereas for a single crown or a bridge of 3 units, a normal mean value articulator will also do. So selection of articulator is a very important topic. Coming to care and maintenance, anything that we use requires care and maintenance. How will we care and maintain our articulator? So the first and foremost thing is lubricating the articulator time to time. Any articulator that we are using, the oil, that handpiece oil that we have, is the best lubricant for any kind of articulator. So what you need to do, you dry out your articulator. There should be no water. Put the oil, not excess oil, wipe out the excess oil and then keep it as it is, like you do for your handpiece and aerators. Similarly, you can use grease for those areas like in condylar element or condylar guidance pathway. In those areas you can put little of grease, but not any petroleum jelly or not any kind of Vaseline or any such. Cleaning of articulator or soap cleaning, a proper soap cleaning is fair good enough for an articulator. No usage of acids on the articulator because it will damage the metal part, the brass parts or the plastic parts. So you should keep it away from the acids. That is another important instruction. And you have to do a soap cleaning. A normal detergent cleaning is okay, advisable, but then it has to be wiped out immediately again. Storage. Where are you supposed to keep your articulator? It should be total moisture free. The atmosphere should be pleasant, not so heated, not so cold. So it can be kept outside, but just see if the places where the things get rust, the metals get rust first. So keep the articulator inside the box, store it and then remove whenever you are into use of the articulator. Every time after the usage of the articulator, cleaning, lubricating is must. So to conclude, articulators are very important for a prosthodontist and a dentist, because when the patient is not along with us and to reduce the chairside time of the patient when the patient entering our clinic. So almost 90% of all the work should be ready with the help of the articulators if our records are proper, the protrusive record is proper, if the lateral records are proper, if the cast that we have poured by making an impression of the patient is proper, the spatial relationship of the cast, that is the maxilla to that of the base of the skull with the face bore recording is proper. So once all these steps are proper and you have exactly mounted the cast in the articulator, how is it in the patient's mouth, then your work is all solved and 90% of your work is ready. So articulator really plays a very important role in any prosthodontist or a dentist's role.